So thanks so much for rejoining the session. Today we're going to be talking about vulnerable populations. In particular, this session addresses AI's dual nature as a powerful tool to close health disparities, but also one that could exacerbate inequity. Panelists will discuss approaches supporting vulnerable populations and mitigating potential risks. My name is Alyce Adams. I am the Stanford Medicine Innovation Professor and a professor in health policy, as well as an Epi and population health. I'm also Associate Director for Community Outreach and Engagement at the Stanford Cancer Institute. I now invite all of my panelists to introduce themselves.
Very good. Well, my name is Rutta, and I'm the CEO of the National Health Council. The National Health Council has been in place for over 100 years, primarily to put patients first. I can't tell you how excited I am to hear all of our speakers really lead with that. But we're the primary association for patient organizations. About 180 national organizations, the majority of whom are patient organizations like the American Heart Association, Cancer Society, lupus, arthritis, to rare disease groups, all advocating for patients to have a voice in the care and in the systems that they rely on to live their lives in a healthy, productive way.
Hi, I'm David Magnus. I'm a professor at the Stanford Center for Biomedical Ethics and in the departments of Pediatrics, Medicine, and by courtesy of Bioengineering. I'm a bioethicist, and I'm also an associate dean for research.
Hi, I'm Natalie Pageler. I am a clinical professor of pediatric critical care and clinical informatics and the chief health informatics officer at Stanford Children's. And one of our major areas of focus is thinking about children and pregnant people as vulnerable populations.
Hi, good morning. I'm Michelle Williams, and I'm the former dean of Harvard School of Public Health, and I'm currently a visiting faculty member here in the Department of Epidemiology and Population Sciences. I also co-chair a public-private academic partnership that is led by Novartis Foundation and Microsoft AI for Health, where AI is harnessed with data to help make better decisions around population health and prevention of cardiovascular disease mortality.
Great, thank you so much. So we've heard a lot already this morning about sort of the promise and perils of AI when it comes to health equity. So my question to all of you, particularly in bias and algorithms, but my question to all of you is, what are we missing? Are there important issues that even aren't getting enough attention or aren't even on the table as we have these conversations?
Thank you. Well, this is an area where I'm most optimistic about this AI conversation and the journey we may be on, because the current system does not adequately include all patients from all backgrounds, all parts of life, and that lack of inclusion, both at the table and making decisions about their own health, but then how that's reflected in health data, has really made them invisible, if not actually discriminated against, as we think about how can we do a better job in promoting health. So I think this whole issue about people who, by virtue of race or ethnicity, by virtue of where they live, rural or urban, by virtue of just how they're connected, maybe there are language issues, maybe there are other ways in which health literacy or ways in which they're connected to the information that will empower them to lead their lives in a healthy way, is so undermined currently by gaps in the health data systems and the way in which patients, their families, and others are engaged in healthcare. So for me, this is a really encouraging part of the conversation.
So while I appreciate the fact that there's been a lot of focus on the missing data and biases that are built into the data, the two things that I think haven't gotten enough attention are, first, the ways in which interests and values, but especially interests, influence the design of algorithms. I do think that the Obermeyer study is often misunderstood. People often say that they made a mistake in thinking about cost as a good proxy for health. It wasn't a mistake. They were selling a product to health systems whose interests are really around cost, not around health. And so when you have these conflicting interests, I think that's really important to really understand. And then the second thing that I think hasn't gotten enough attention that's just starting to be looked at is the way in which different models can be actually intentionally misused. It can be misused in ways to help create bioweapons. It can be misused in ways to help increase surveillance in different ways. And so I think we need to be very aware of the potential for misuse and take advantage of all of the incredible work that's been done in other domains to really be able to protect from those kinds of misuse early on in the design process.
Yeah, well said. And I'm reiterating kind of a lot of what's been talked about, but the way I think about this is when we're trying to think about AI and potential potential misuse or bias that may exacerbate disparities. I think about it in 4 buckets, and like the first is who shapes the question that you're asking? What kind of data is included? And again, from a pediatric perspective, pediatric pediatric data and data for pregnant women is often excluded for lots of different reasons. And then, is there inherent bias in the algorithm itself as that third bucket? And then the fourth bucket is how do you use the algorithm once it's created? And there's, your examples are really key. There's examples of that many people have given before of how do you use an algorithm that predicts no-shows in clinics. Do you overfill the clinic, or do you reach out to the people who may be disadvantaged and have increased barriers to getting to clinic? For me in pediatrics, an example that we often deal with is it's really hard to engage children, families, and especially teenagers, and there's a lot of nuance involved in that. And while you often want the family involved, you also need to think about the very vulnerable teen populations who won't seek care if they don't have a confidential relationship with their provider. And so at Stanford Children's, we've created an AI algorithm that can detect when it's actually a parent inappropriately speaking with a provider through their patient portal. But how you implement that has huge implications. And so, you could, in a very cynical sense, choose not to use that algorithm at all and pretend like you don't know that's an issue. You could just shut off access to data and shut off access to the portal for both teens and parents. And there are many organizations that have done that, and that exacerbates the disparities for both teens and their families and children that otherwise would be supported by their entire family. Or you can do the really hard work to figure out where is that problem coming from and how do you improve the system so that you can better engage all the different people that might be involved in a child's care. So, anyway, I think it's just so critical that we're looking at each of those 4 buckets and how we prevent bias, how we prevent accidentally exacerbating disparities.
So I'm going to take a different tact and say, basically, we heard something this morning from Mike Howell where he said health is more than healthcare. And that opens up for me the opportunity to talk about the big missing piece of the 80% of the drivers that drive health and wellness. And those are the social determinants of health. And so if we really are about harnessing the power and promises of AI, we have to be really serious about another thing I heard, which is to be data preparedness in the last panel. And so what we're missing is really thoughtful, rigorous, expansive, holistic understanding that AI is only going to be as good as the data that the models are trained on. And if we are looking for improving health, decreasing disparities, we're going to have to make sure we are collecting high-quality data on human behaviors, as well as the social and physical environment.
Fantastic. And I love that framework you gave us, Natalie, for thinking about these different components. And to your point, Michelle, about optimism, right? So there's a lot of dangers out there, but there's also a lot of potential. So let's sort of weave into that optimism a little bit and talk about what are the compelling ways in which AI could be used potentially to advance health equity. And I'm wondering if you have specific examples from your own worlds.
We definitely do. I think, again, the current system, as marvelous as it is and what it brings forward for so many people to live healthy and full lives, for so many of the people that I represent, about 160 million Americans with chronic conditions, complex conditions, comorbidities, age-related impairments, the current system just isn't serving them well. So as they look at what's possible in AI, it might start on the innovation level. So could clinical trials be more diverse by using AI that really closes some of those gaps to so many people that have been invisible and not recruited? Might there be molecular design that the bench scientists just aren't perceiving yet, but AI could identify? More than 90% or so of people with rare diseases don't yet have an indication, a treatment that's going to help them address their specific need. They're using off-label, they're using other products. They could see tremendous potential. And you hear the conversation about the N of 1 kind of research that could occur. These are miraculous for these families, these individuals that really don't see sufficient hope, in the current system. And then you talk about, well, how is it that we could use AI to better bring information to the patient. Talking even about labeling uses and things that would really help a patient understand, but the AI would need to understand who they are. Are they a first-generation American? Is English their first language? Translate that medical knowledge that's, by regulatory requirement needs to be there, but translate into something that with their physician they understand it could be life-changing for them. These are just a few examples of, I think, why the patient community, always concerned about privacy, always concerned about how their data is used, prioritize these more optimistic aspects of AI.
So this could go either way. It could either be something that exacerbates inequality or lead to helping to improve things. We've done some research where we've looked at listing decisions for transplantation and a lot of biases in clinical decision making. So physicians, not just AI, physicians are often very biased. They discriminate against children who have developmental delay. They discriminate against people who are undocumented immigrants. There's a lot of things that we know happen a lot and quite frequently. If AI learns from the outcomes that happen with those patients, it would be problematic, but there's at least the potential for AI systems to learn that you get just as good outcomes from the places. The key to that is going to be data sharing across institutions. But if you have that data sharing across institutions, there's a potential for AI to recognize the kinds of biases that exist in clinical practice and help lead us to correct some of those biases.
Yeah, I think just the fact that there is so much attention, thankfully, from the beginning, kind of the beginning, on the algorithms and the potential for bias and the potential for exacerbating disparities is really encouraging. And as we kind of take that lens and ask the questions, I think we're finding interesting answers. So again, I'm going to be very pediatric focused, but one of the things we worry about is the inappropriate application of AI algorithms that are developed in adults on children. And so we're asking those questions, and there's some surprising answers. So for example, Scott Sarasnik is one of our cardiologists, pediatric cardiologists, and looked at the Apple Watch in children. And you would think, it was developed for adults, it was developed on adult data, and yet they were able to show that they were getting very reliable, interesting information on children who are wearing Apple Watches. And there's potential to really incorporate that into pediatric cardiology care going forward. So I think the fact that we're asking the questions is leading to some surprising answers where there is opportunity to apply algorithms that were developed for one use safely in another, and thankfully we're testing that to make sure that's truly the case.
These are great examples. There's hope in that comes from the last conversation, the last panel where we talked about public-private and academic partnerships. I like the idea of adding academics in there because you can turn PPPs from being transactional to truly being transformative. And I think the public in public health are the agencies who are charged with protecting, preserving, and augmenting health. And they are the ones that also have a lot of the health data outside of health systems and hospitals. And so if we can really develop a data ecosystem where there is transparency and sharing and appropriate governance, these PPPs really have the capacity to work together in developing algorithms that can make public health more proactive and less reactive. And it can also, give meaning to the full continuum of health.
Fantastic examples, and it has me thinking about sort of this idea of AI and health equity. We could think about it as optimizing health equity. You can also think about what are the constraints that we need to prevent harm, right? And so this is constant balancing act. Thank you so much for that. So we're going to go ahead and turn to questions from the audience. I'm going to start on the Zoom, and then we'll take some here in person. So the first question is, thinking about historical marginalization of underserved communities, how can we as a collective hold entities responsible for creating space for patients and families from these communities to be part of conversations about AI and the role of AI and access to their care? Someone want to start?
I'll start. So I'm the co-chair of the IRB for the All of Us research program, and they've been very successful at being able to recruit into populations that are typically underrepresented in biomedical research. And the biggest lesson, it's not that we don't know how to do this, it's that we don't actually implement it. We make things open by saying anybody can come to Stanford. Anybody can come to academic medical centers, but not everybody does, and not everybody feels welcome, not everybody comes. So I think the really key is to reach out to those audiences and reach out to those populations that have been underserved and underrepresented in research, and go to them and go to the institutions that serve them. There's just barely beginning to build the resources to carry out more research in FQHCs, but things like that, going to FQHCs, going out to churches to recruit people in communities of color, doing all the other pieces that you need to do to really reach those populations, partner with people who are trusted to really do that. And it's expensive, and it makes the research harder in some ways, but it's been demonstrated that all these things do work, and lots of examples exist around the country of groups that have built these kinds of partnerships and done that, and there's programs at Stanford, Sphere, and others to do similar kinds of things.
I want to double down on that, because I think it's really important. It is expensive to go out and build and maintain and sustain these community-based partnerships, but so is it's expensive to have your mass spec, calibrated and updated every 2 years. So I like to think about community-based engagement as something we have to invest in, something we have to enhance and support, even when we're not writing the R01 grant, right? And put value into it, but also recognize, enhance, and support those faculty members and staff who are building and maintaining these relationships.
That's great, and you're sort of thinking about it as, it's part of good science, right? It's not doing something extra because we have to. It's part of good science. If it's part of good science, and it's worth putting in that supportive infrastructure to make it happen.
Laboratories without walls.
Yeah.
Right.
Thanks so much.
Let me
Please,
just
Randy.
jump in on that. I think one of the examples that was shared, or a comment that was made earlier, was that in some ways the healthcare community, that's certainly true of our patient organizations, are still kind of coming out of the pandemic. But one of the great things that happened during the pandemic was that it forced all of our communities to engage virtually. And so what we saw is, right now for groups coming to Capitol Hill and advocating for these exact same issues, they might have had 200 people that were able to actually come into Washington. Well, now it's 400 are coming in, but 4,000 are online with their legislators and helping them understand what's important to them. I mean, the power of how the pandemic and just the way in which our society has gravitated toward being more inclusive and responsive has put us in a position, I think, better than we've ever been in. So as I'm listening to everyone say we value patients, patients should be involved, I'm thinking, how can the patient community itself, oftentimes with somewhat stretched or limited bandwidth, not necessarily expert on designing algorithms, how can we meet you more than halfway so that you truly, almost for the first time ever, have the kind of meaningful patient engagement that leads to real change and is reflected in the system, and ultimately the personal health and population health outcomes we're looking to achieve in ways that the system so far, even where it's given lip service or value statements, because sometimes I look at the value statements of many different entities and wow, they could be the National Health Council. It's like, oh, I love that. But then how does it get translated? And I think the Academy and others have done a really good job in saying we will create meaningful places and support that engagement in meaningful ways so that we do differently from this point forward. And I think AI could be that driver.
That's a great point, Randy. And I'm going to paraphrase one of the questions that just came in and double down on what you just said about meeting them more than halfway. How much of that is about power and power dynamics and what they mean for who's really in the driver's seat with respect to AI?
I think some of its power, some of its more traditional roles, I think I give the benefit of the doubt to anyone who is involved in healthcare from bench to bedside. I mean, people really are motivated to do the right thing for patients. And we talked about this as being a session on vulnerable patients. Anybody who's a patient, more than just a healthcare consumer, is vulnerable by virtue of trying to understand what's happening to them or a loved one and are anxious about that. But I think the more than halfway piece is going to really be critical. But I think the patient community has never been more energized and ready. And I think we've never been able to see how the benefit could be greater than where we find ourselves right now.
Fantastic. Thanks so much. So I think we're going to go to the room. There's a question here in the front.
Thank you. My name is Hattie. I'm a primary care doctor in the UK and one of the chief officers for the NHS Health Innovation Network. My question is about remote, rural and coastal communities. So a couple of years ago, we published a report, our chief medical officer in the UK published a report about poor access to healthcare for those communities. And we published an AI roadmap a couple of years ago which showed the spread of AI in the NHS. And it tends to be in the golden triangle of London, Cambridge, or Oxford, or in urbanised populations, Leeds, Manchester, Birmingham. And I get the impression it's similar over here. How do we start to move these technologies to where they might have the most value to help tackle some of the challenges for those types of communities?
So you identified those universities that are well-resourced with funds to support very creative, very imaginative, and highly selected faculty. What I would say is the AI accessibility follows resources. And so we need to be intentional in making sure as we develop and enhance the tools that can come to support healthcare, that we are intentional in closing those gaps. That's, I think about the internet. I think about, I could be in Philly and I can be at Walgreens and I can get a quick checkout at the counter because the broadband's great. But I could be in East Stroudsburg, Pennsylvania, and I've got to wait 10 more minutes because the broadband is not quite as good. Or in the middle of a pandemic where, our kids are learning at home, but those kids who don't have broadband are left behind. So I think we have to think proactively about where the vulnerabilities are, where the gaps are, and design with that knowledge to make sure we're not widening the gaps. And it's a universal problem, right?
I would also say having those people at the table, right? So we've made making a concerted effort when we're doing research, whether it involves AI or not, to make sure that we have rural representation at the table for a couple of reasons. One is the reasons that you just mentioned. There's also a lot of opportunity there. I mean, the opportunity for innovation is huge in places where you don't have a lot of access to healthcare, right? The needs are complex, and they're sort of the kinds of questions we should be asking. How can AI help?
I think we're seeing just, with the NHS and some of the experiences you just mentioned in the UK, I think we are seeing that here where there's tremendous pressure on current systems that are just failing. You think about rural health systems and the way in which those systems have been supported. It gives us an opportunity to say, well, that didn't work, so we clearly have to do something different. And what I would really encourage you to do, and I've heard so many say this, I know Chai is in launching the initiative, has patients and get embedded in every single working group. And it's not always easy to find those patients. I would do the same in kind of the reinvention of how these previously underserved populations may be better served. And again, I think we'll get to a better place in that space.
Fantastic, yes.
Hi, thanks for the great insights. My name is Krishnaram Kentapadi. So I just started in a role at Oracle Health AI. My question is about your thoughts on both the challenges and opportunities for AI when it's used for healthcare in countries where there is limited healthcare to start with. Countries like India or many African countries. There again, what are your thoughts on vulnerable populations and how we can apply AI for healthcare without increasing those vulnerabilities?
Okay, so one of our postdocs is from Niger, who works on AI ethics and is working on this problem of how does what we learn in the U.S. apply when you try and think about how it's going to work in the low-income countries and some of the lowest-income countries. And I think the answer is right now it's not clear, right? Insofar as these things are being developed in the U.S. and in Europe, we already learned that it may not be applicable to other communities even within the country, much less that it's going to be applicable in populations that are facing serious food security issues and so on, and where there just isn't any healthcare to be accessed at all. So I think I think it's also going to be the case that we can't treat all of these countries similarly. I think some countries have built internet infrastructure in more rural areas, and some countries have not. And I think that's going to make a big difference for whether or not AI has the potential to be beneficial in some communities that are severely underserved right now, or whether or not it's going to exacerbate inequalities. So I think it's a hard problem, and I think it's one that deserves a lot more attention. But I do know it's something we've talked to folks in industry, some of whom are in the room, who in the pharmaceutical industry, who are very keen on these kinds of problems and worried about that. So I'm somewhat hopeful that there's room for academic, public, private partnerships in this space as well to try and help address some of those issues.
I know of one really nice example of an academic center that's led by someone who used to be here, I think, and is now at Harvard, Milan Tandy. And, he runs a center for AI for social impact. And it's a wonderful incubator for learning context-specific needs and engaging in providing solutions that increase access, and doing it in a way where you're training the next generation of care providers, causal inference specialists, as well as clinicians. So there's hope, but I think the scale up of the kinds of investments that would be needed, from electrifying parts of Africa, which doesn't have electricity, to providing broadband access, to doing ed tech so that women and girls who are currently out of the narrative in these countries can be brought in. It's going to take time and effort, but it can be done.
Asked a question. Thank you. Yes, in the back.
Hello, can you hear me? Vlasta Pokladnikova. I represent a couple groups, actually. Stanford alumni in AI, a newly formed group, and Stanford alumni in healthcare. And my question is, 70% of determinants of health are socioeconomic. And so I was just wondering, what initiatives or research have you seen that focus on this area? And what do you think, how do you think AI could help and make a difference?
I'd love to take a first shot at that if I can, because it's something I'm quite interested in. I do think so. So here's how it could make things worse, and here's how it can make things better. The ways in which it can make things worse is, and again, I hate it when we talk about this as a bias. It's not a bias. The social, it's something that it's caused as a function of decisions we've made about this kind of society we have, that we have these social determinants of health. That means certain people who are poor and people who are of color are further down on the health wealth gradient, the disparities, the excess death in those populations. Those are very real things, and it's not a bias if an algorithm that's learning about what's in the electronic health record data learns that those populations have those outcomes, because it is about the kind of society that we have. So the risk is that as AI systems learn about those outcomes that are a function of these social determinants of health, it may reinforce those inequalities and be problematic. But the hope is, every time we have an opportunity to hold up a mirror, AI is a mirror that reflects the society that we're in. So is COVID. Every time we have something that's a mirror that shows what is going on in our society and make the public aware of something that researchers in public health have known for a long time about the social determinants of health, and some ways of trying to make things better and address that, which we are abjectly failing to do. So I'm hopeful that every time we get an opportunity to sort of shine a light on this problem, hold up that mirror to ourselves, hopefully this will be a spur for things to get better.
That's well said. It's the AI doesn't introduce the bias. It's just a function of the structural biases that exist in society. There are some emerging examples, and I mentioned in my introduction that I serve as a co-chair of global experts for a public-private and academic partnership supported by Novartis Foundation and Microsoft AI for Health. And the whole goal of this initiative is to harness public available data, EHR data, and other data in the systems of public health agencies, and with their engagement, complete engagement at the table, try to develop algorithms that would identify specific areas within cities. And right now the project's in New York City, Singapore, Helsinki, and Basel. Sadly, not yet any of the global south cities, largely because of the lack of data preparedness. But if this partnership can help use the available data to identify the biggest drivers of premature mortality, and that information can then be put into the hands of health commissioners and urban planners and educators of cities, can they make better decisions that are more holistic in improving the health and wellness of their population? I think that's an example where, if used properly with the right set of stakeholders at the table, including communities, you can harness the information that's all out there but not yet well prepared to enhance decision making.
To add on to that, and you've said this multiple times, I think it's very well said, like using the available data to ask the right questions to enhance decision making, and recognizing that a huge piece of it is thinking about how do we expand what the available data is. And so many of our questions get shaped by what is easy, and when you're thinking about social determinants of health in particular, it's important to ask that question and to get that data. I would say the follow-on piece to that, though, is by sometimes sharing that data, you're making them patients and people more vulnerable. And so it's really important that you close the loop and that you do something meaningful with that data to help them and don't just exacerbate the vulnerabilities.
One last question online. Oh, did you want to?
No, it looks like you might have one.
Oh, thank you. Go ahead.
Hi, my name's Roy. I'm an Australian primary care physician and an early stage founder building workflow automations for healthcare providers. I'm a first generation migrant from a war-torn country. And so I asked this question with that context. There's a paradox when building products. We prioritize what is best for the masses. But this is a very important factor, and the reason why I entered into the medical field in the first place. What would your advice be to myself as a founder, as I'm grappling with, trying to compete, incentives to satisfy investors while building something in health, and how are you speaking to the big tech companies who have already put out products that are, that carry inequities and bias? Where's this conversation to those developers? Thanks.
I can start us out at least. I think just people that are at that early stages of the innovation life cycle cannot involve patients, that intended audience for benefiting from whatever it is you're pursuing early enough. And so this is a message that we know plays out to the advantage of both those products and the AI tools that are being talked about here in this room. It certainly plays out, and it's a wiser investment of resources that will ultimately improve patient and population health. One of the ways we're supporting that in the medtech arena is that there's a group called MedTech Innovator, and they bring hundreds of organizations, early innovation companies together to try to help them navigate the process of connecting not just to investors, but potential consumers and others. And we're inserting the patient organizations themselves and those patients in those early clinical trials, those early conceptual conversations, so that when that product starts to move forward, and it may be 3 years, 5 years, 7 years before it goes to market, the FDA, the others that have played a role in kind of shaping that journey, know that it's been informed by the patients themselves, and that can only lead to a better impact. And I think that goes for everything that's been said in the room, this intention to make sure that wherever AI takes us in this journey, we will start with the patient, and then that will then have an impact on population health. I just can't encourage you to think as fundamentally and creatively as possible. We have tools. We have something called patient experience mapping and evidence-based tools that many of you in this room have used to really just ask the question, so how are patients experiencing whatever it is that we're doing? doing. It's so rare that that happens. And we're finding that there's incredible insights, many that speak to social determinants of care as well as to the actual goal of that care experience. But I would also say the value conversation. Is the value conversation taking into account the value that the patient wants to get back? And patients are pretty discerning in how they want to use healthcare. It's not, oh, those patients, they'll ask for everything. No, they're usually pretty careful consumers, but they want to know that whatever they're seeking from the healthcare system will benefit them and the goals that are important to them. And that is a person-by-person kind of discussion. And the last thing I'll say is we don't want to be so rigid in how it is we think that patients will be involved in these systems that makes us over-reliant on the system we currently have that is so often biased toward resources payment. It's just so much a conversation about who will pay for what and how is that going to be, reviewed and approved and et cetera. And suddenly the patient feels very marginalized. And the interactions they have, which are so often about coverage and payment, alienate from the very system that I'm hoping AI could make maybe more personal and more directly appropriate.
Yeah. As an immigrant and someone who does a lot of work in the global spaces, I would say to the for-profit community, there's untapped opportunities in places like India and Africa where, so much of the continent don't have access to technology, but if they did, think about that market that would be there. The other thing that I would say to social impact investors, there's a lot of creativity and talent in these places that don't have the resources to build accelerators and bring that young talent into spaces where they could be mentored and encouraged to pursue interesting innovations that will address local problems.
Thank you so much. Please join me in thanking all of our panelists for this discussion today.
Thank you.